Hi guys, how's it going?
Good.
Thanks for joining. We've got a big one today, so I'm inclined to kind of just really launch into this. Now, radio, you can see the slides there.
Yep.
Hey Ellen. Hey Nick, got your question, thank you. All right, guys, let's really launch into this. Thanks for joining us for this month's episode of Blister Prevention Office Hours. We're going to go through what to do with blisters in terms of the integrity of the blister roof. Some races, not a lot of races, but one in particular, particularly Marathon des Sables, they routinely deroof blisters. But yet most medical advice recommends not to lance, to actually keep the blister intact. So there's a lot of confusion around this issue, how to treat them. I usually lance blisters in the athletic situations, particularly that I'm at, but not all of them. Some of them I leave intact, and we're going to work out when and why. And I rarely deroof a blister mid-race. It'll usually be like an after the event kind of a thing. So let's quickly look through the stages of the 5 stages of blister. We've got the stage where we have no blister, we're blister-free. We've got the hotspot next. If we don't do enough to stop the blister causing forces, we end up with a blister with his roof intact. When we lance a blister, we are essentially giving it a torn blister roof. And then, of course, there's the deroof stage. So let's have a look at these pros and cons. So the pros for leaving a blister roof intact is that it can't get infected because it's closed, it's sterile. That is the #1 reason why most medical advice is to leave it intact. It's a bit of a generalization, but it's probably, if you want to make this real simple, because people ask a question, they want like a yes or no answer, then the answer is leave it intact. But I hope to go through the nuances of this in this presentation. Also, it's no problem to you because you've got scalpel blades and hypodermic needles, etc. But your patient may not when it comes to the point where they need to lance their blisters at home. They might not have the gear that they need, and they might not really even know how to do it. So really, to leave it intact it's easy because you don't need any gear. However, we know that blisters often spontaneously burst or tear. So you could argue that you still need some expertise in gear because you need to stop those blister causing forces. Otherwise, you'll end up with a torn blister in an uncontrolled environment. So yeah, the downsides are the blister often gets worse in an athletic situation anyway. Like if you're seeing something, you'd have to be doing race support. If you're seeing a blister halfway through, you know it's kind of going to get better unless you do something about it. So it can be a good idea to lance the blister knowing that it's going to fill further, and it can help it not hurt as much. It often tears spontaneously, as I said, if you don't do anything. So it's better, you could argue, to do it in a controlled and clean environment, but it still needs monitoring. So it's not like if you leave a blister roof intact, job done, it's not going to get worse, everything's happy, because you still need to make sure that it doesn't tear spontaneously. You still need to I guess make sure it's not infected as well, for the same reason. The pros of lancing a blister roof: can reduce discomfort, but really the best way to reduce discomfort, whether you lance it or not, is to get a really good shear reduction strategy in place. That's really how you make things feel better. But yep, lancing can reduce the discomfort. You're doing it in a controlled environment, it's nice and clean, so you're reducing or you're minimizing infection risk, but it's not negated because it's open now. One thing I will say though is you'd be surprised how quickly, when you lance a blister, how quickly it sort of seals up again. I've seen them the same day, even like say 5 hours apart, where we lanced it, and 5 hours later it was filled again. It was an intact blister roof. So yeah, it just you want to kind of make a small opening, but at the same time, if you want the blister to keep draining, then it can be an idea to make it a bit bigger rather than smaller. So yeah, a bit of nuance there. And when the blister fluid and blood and whatever's in there, kind of as the blister is resolving, it solidifies and it kind of crystallizes, and that can become a bit of an irritant. So it gets rid of that issue. The downsides, obviously, is it opens it up to infection. You need to have the gear, so the sterile implement to lance the blister, enough dressings for not just that episode, but obviously it needs to be dressed ongoing until it's fully healed. So it needs that ongoing care and monitoring to make sure it doesn't, in fact, get infected. Deroofing the blister, the pros. Well, if it's infected, sometimes it can be hard to get the antiseptic in and under the blister roof. Depends on the anatomical location, depends on how big it is. But if you deroof it, then you've got access to the whole blister base. If it's soiled, you can clear the debris and clean it better. I've seen situations where there's been a relatively big blister, there's all dirt and gunk in there, you just can't flush it out. So sometimes it can be better just to deroof it and make it nice and clean. And obviously, if you deroof it, it won't refill. The cons are it increases infection risk because you've got a bigger surface area. There's less innate protection. So when you lance a blister, you're getting the fluid out, but then the skin's still over it. So it's like a bit of protection. Having said that, sometimes the blister roof ends up being an irritant, particularly if it's dried out, particularly if it's macerated. So that one, you just have to take it case by case. Deroofing obviously needs some gear and expertise. Some patients, probably most patients, won't be that keen on deroofing their own blisters. It seems a bit too much, which is fair enough. So they'll need your expertise there. What about high-risk patients? Well, the priorities in treating, we're talking immunocompromised and neuropathic diabetics and that kind of thing. Really, the aim when we're treating these patients is to maintain skin integrity. So there's a big case for just leaving that blister intact. But don't just leave it intact and think, I've done the best I can because it's intact and it won't get infected. There's nothing to say that 5 minutes later it's still going to be intact. So you really need to offload the shear. You need to implement a really good shear reduction strategy. We're hardwired into just thinking pressure when we say that, but there's other things that you can do, and we're going to get to that a bit later. Yeah, keeping it intact also takes infection out of the equation, at least at that point. Again, got to offload it, otherwise it will tear. The self-care is a tricky one. So if you leave a blister intact and you send your patient on their way, can they see their blister to reassess it? Are they going to need some follow-up even though you've left that blister intact? So you could argue that even though you've done nothing with the blister in terms of opening it up, it still needs some professional monitoring and treatment. So let's go through some examples. What would you do with this one? Would you leave it intact? Would you lance it, or would you deroof it? I'd probably leave it intact. Now, the reasons for that are it's not particularly distended with fluid. This was at the end of the activity. They've got thongs on, so they've had a shower after the race, and they've got no immediate activity coming up. So let's say it's the weekend, they've got a few days to recover before they've got to put their work shoes on and go to work. The location's not impacted by weight bearing or footwear. So as long as they can get around in thongs for the rest of the weekend, then it gives it every chance to resolve. They're able to get to their feet very well to be able to keep an eye on it. And, if they have to put an enclosed shoe on, just to at least put a Band-Aid over it. And they're healthy people. This was a healthy person. But what would you do if you saw this and this person had to, say, play netball tomorrow, or it was mid-race? Would that change what you would do? What do you reckon?
Address.
I'd probably still leave it intact. It's not inflamed or anything. It's not reddened. And I would just implement a really good prevention strategy. Put an island dressing over it, and the prevention strategy would probably be making sure the shoes are wide enough in the toe box, making sure they're lacing firm so the toe's not ending up in the end of the toe box, which is narrower, and putting an Ango patch on the shoe, which is a good way of reducing shear. I love gel toe sleeves for toe blisters in prevention, but I'm really dubious about putting gel products on already damaged skin, even intact blisters, because it can macerate it, and that can make the whole thing worse. So if we are, I would consider maybe having a gel toe sleeve over this if we had an island dressing on first. That's my call on that one. How about this one? Would you leave it intact? Would you lance it, or would you deroof it?
Leave it intact.
Bit nasty, hey? I'd probably lance this one. It's pretty distended with fluid, and I think the chances of this spontaneously tearing are pretty high. There's constant irritation from the fourth toe, which is hard to avoid. It was the end of the activity, so let's say they've got the weekend for this to resolve, but still, you know, there's even come Monday when they've got to go to work, there's still going to be, you know, some blister there. It's not going to fully resolve. Some of that blister fluid and blood will probably be on its way to getting firm and maybe even crystallizing. They're able to get to their feet. It's relatively clean, so they can self-care, and they have no immunocompromise or any high-risk health problems. The complicating factor is there's blood there. So blisters are an injury of the epidermis, so there should be no blood in them. But if the injury goes a bit deeper, then of course we can get blood entering into the blister fluid. So when we see blood, we think, oh, we're just a little bit more cautious of the whole infection side of things, and really making sure that people are able to self-care, got enough dressings, etc., to be able to deal with this. And what if you saw this person, they had to return to their activity or their job and they're on their feet and they had to do this tomorrow? What if they had poor self-care or they were immunocompromised? Would that change anything you did with this? In my opinion, it probably wouldn't change anything. I would still lance this. I don't think there's any reason why I would deroof it. But it kind of needs lancing because it's kind of going to happen on its own if we do nothing. And it's just so difficult to implement a good prevention with all of that fluid bulk there. Next one. So we're talking about not the black toenail. Let's assume that one wasn't painful, so we didn't have to deal with that. Not the second toe, that's just dirt. The third toe is definitely grubby, but there's a toenail blister or a blister under the toenail, lifting it up a bit. You can see at the base of the nail, there's blood in it, and it's making kind of the nail sit up. What would you do with him? Would you leave it intact? Would you lance it? Or would you deroof it? I would probably lance this, but I would also lean towards maybe leaving it intact, depending on how well I thought that I could get rid of the blister causing forces. So it's distended with fluid and it's making the nail sit up. This is obviously mid-activity. This person's in the bush taking their shoe off to find this. In this situation, let's assume that the person had their shoelaces a bit too loose, and so the toe was impacting at the end of the toe box, or perhaps there was a lot of downhill walking or running. These are the situations where we tend to get that impact at the end of the toe box, with the toes at the end of the toe box. Generally, toenail blisters are caused by clawed toes more than actual impact, unless the laces are too loose and they're doing a lot of downhill. So let's say it was the lacing. Yeah, we're pretty happy that the shoe's the right size. We can keep the heel back to keep the toe out of the end of the shoe. We could just clean this up and leave it intact. But if you were happy that you could clean it up, the person had enough gear to deal with this at the time and also ongoing, and they could, you could make sure the shoe wasn't too grubby, because really infection risk is the biggest risk here. So yeah, I would lance it, but I would also be more than happy to leave it intact. The grubbiness and the blood and the mid-activity kind of bothers me a bit, so I'm sort of undecided on this one. If you added something like they had sensory neuropathy, or, you know, let's say this wasn't an athletic situation and just someone came in with this toe, they can't get to their feet, they can't really see much, they just know their toe hurts a bit, or perhaps it doesn't even hurt, and they live alone, so there's no one else to do anything. What would you do? Would it change what you did?
Yes.
What would you do, Alan?
Can you hear me okay?
Yeah, what would you do?
Right. Well, two different circumstances for me. I'm a bushwalker, multi-day expeditioner. If this was a day walk, I'd tend to clean it up and just leave it alone. If we were day 3 into a 16-day walk, I would lance it, clean it and dress it, and then manage it as the expeditioner first aid for the rest of the trip. If it came into my clinic, I see this often, and diabetic type, high-risk diabetic, I would deroof that and dress it, because if you can't see the base of the wound, you can't assess the wound. So you're not quite sure if you just leave it in the clinic situation with a diabetic. So I think the situations, all of these are different depending upon the circumstances.
Yeah, the tricky thing with this, if you deroofed it, you'd be taking the nail off as well, which is no problem if that's what's got to be done, because the nail's lifted right up. So yeah, you would have to, there's a lot to consider, isn't there?
Yes, I think it's different in the circumstances. So if someone presents to me in my podiatry clinic as opposed to a bushwalking expedition and they have a diabetic complication, then I would remove all the tissue, remove all non-viable tissue, and then start a dressing and management regime upon that, which would be very different to what I'd be doing in the field.
Yeah, that's a fair call. Very good, thank you. Alrighty, what about these ones? Is this a leave intact? Is it a lance or deroof?
Lance.
Lance? Yeah, I would lance. Even though we've got blood there. So it's relatively taut, it's tracking. When I say tracking, what happens with these edge blisters is the cause of the blister is sort of along this area, and because it's a relatively high pressure area, it just pushes all the fluid elsewhere. So it's easy for our patients and even us to think, oh, the problem's here. It's not here, it's actually here where this callus is, and the callus really should have been the giveaway. So it's here that we've got to implement the prevention, or at least don't just sort of do something here. Just think about this whole edge. Anyway, so it's relatively taut, it's tracking. It's the end of the activity. It's semi-impacted by weight bearing of footwear because it's on the edge there, but the activity has reduced. So, you know, it's quite clean, even though there's some blood there. This is a healthy person, they're able to self-care. So yeah, I would lance, even if they had to go to work tomorrow, lance, get the fluid out, implement some good shear reduction. I don't think there's any reason why I would deroof these, but I'd like to get all the blood out of there just so as it dries, it also doesn't become an irritant. If this was more of a high risk patient, especially. How about this one? Is this a leave intact? Is it a lance or is it a deroof?
Well, if you don't lance that, you're gonna, yeah, I would lance. If you don't lance it, it's gonna blow up on you outside your vision.
Yeah, the thing about plantar skin is it is thicker and it's more resilient to hold. It's more able to hold a fluid-filled lesion, but you can see that this one's already tracking. So the issue is sub-second. and it's kind of tracking up here. And some of these are the ones that you see end up between the toes if there's more and more fluid. And you think, gosh, what's going on in this interdigital space? But the problem's actually down here. So it's moderately distended. It's impacted by weight bearing. This is a healthy person. It's on a clean foot. They have good self-care ability. Let's say this was at the end of a netball game, but they've got training in 3 days and in 5 days, and then the game next week. So, yeah, I'd hate to think that this person sort of continues to play with this happening, because it's just going to get worse. Like, even if I implement the best of preventions, I still would like to lance this and just get that fluid out. In lancing isn't that, if you're able to lance and the person can sort of look after it themselves with antiseptic and a dressing, lancing isn't the boogeyman that I guess sometimes it's led on to be. You can put such a small hole in these just to get that fluid out that it heals up really, or it seals over really quickly, to therefore keep any further bacteria out. So, but it really just depends on how much you can implement shear reduction. Even whether you lance it or whether you don't, you've just got to implement a really good blister prevention strategy so it doesn't get worse, and so it starts to feel better with the extra impact of netball, but just general weight bearing. And so if this came into my clinic on a Monday, I would be putting a good prevention in all their shoes, not just their netball shoes, because I don't want to have any blister causing forces on Monday or Tuesday during the day when they're at work, when they're at school, whatever it happens to be. Same thing, mid-game, it wouldn't bother me. I would still lance it and do exactly the same thing. If they were immunocompromised, I mean, Alan, would you deroof that?
I wouldn't deroof it, but I would still lance it. I think that the immunocompromise is a red herring, because it really shouldn't interfere with what you're going to do in terms of the mechanics of the lesion and what you need to do about it. So whether they're immunocompromised or not, if you don't do anything about it, it could, as you can see, if they're going to run around on this, it's going to break out or get worse, and you'll deal with a much larger skin lesion. I tend to view most of the blisters in my area of work and in expeditions very similar to a skin tear. So if you get a skin tear, you try and get the skin back over the lesion and then dress it. So I use a number 15 scalpel and slide it in perpendicular to the side of the foot into the blister, drain it, and then I'll dress it with one of those little, those little neat little silicone mesh dressings that you can get. They flex, but they hold the structure of the skin together very well.
No, I don't.
And that works well, and work them similar to the same situation as if you had a skin tear.
Yeah, I agree. Like the immunocompromised, the peripheral neuropathy, I know that our aim is to prevent infection, but it's not the only thing that we're trying to do. Yeah, so I agree wholeheartedly. Okay, a couple more for the forefoot. These are more likely the types of things that you'll see in clinics, so they're kind of resolved or resolving blisters. So it's not really a question of are we going to lance these or deroof them, because there's not a lot of fluid there. But the fact that this has happened should make you think, oh gosh, like there's a lot of shear here in whatever the activity, and it could just be normal walking. The one on the right I know is the netball blister. You've still got to implement blister prevention, because it's more than likely going to happen again if that activity is going to happen again. And don't forget that calluses are caused by the same thing that blisters are caused by, repetitive shear deformation. So it's a lot of your patients might think, oh, I've got to get these calluses off and that'll stop me from getting a blister. It's not really like that. It just means that these are red flags to say I'm more than likely going to get a blister around here, because there is obviously repetitive shear deformation. Callus is the chronic manifestation, blisters are the acute manifestation where there's no time for it to adapt. What about this? So
has it been debrided?
No, these are the patient. This is in the Marathon des Sables. They lanced them themselves. Apparently, it wasn't infected, although it looks a bit gooey up here, like sort of thick fluid coming out of the blister. The red, I think, is more the antiseptic they were using. But let's just say someone came in with this size blister and all this kind of here. How would you deal with this? Would you deroof it? What do you reckon, Alan?
On a multi-day expedition, if you deroof that, you'd nearly need a medevac rescue, I'd say, because you wouldn't be able to be in a situation where you could keep it clean enough, and they wouldn't be able to walk on it. If you remove that much skin from the area, they wouldn't be able to walk.
Agreed. And it's hard to get a dressing to sort of cover all that area, not even a hydrocolloid, because, you know, it's the hydrocolloid, you need like a margin around it. So just because of the size of this and the weight-bearing location, I would just lance, dress, do what you can infection, you know, antiseptic-wise, getting an antiseptic into there. And, man, you've got to implement some great prevention for that person to be able to keep going. How about this one? So this is a torn blister. It's macerated. So basically what happened was there were wet conditions, and this person had a blister here. It tore, saturated the insole at more than what was already sort of wet from the wet conditions. And you can see all this maceration here. So we've got a macerated blister roof, which is torn. It's not just a little tear, it's a relatively big tear, but the skin is relatively, you know, you could just hoik that over and cover up that blister base. So I probably wouldn't deroof this, but with macerated blister roofs, I often do. It's the location here, the wet conditions, and I can't implement great friction management when things are wet and when we have a dressing in place. So the best way to reduce friction are things like Engo patches, armor skin socks, lubricants. You can't use lubricants because it will muck up the adhesion of the dressing that you put on. Can't use Engo patches because the insole's saturated. Armor skin socks you're unlikely to have on hand. So getting, really all you've got is pressure reduction. You can't really put gel stuff here because it'll macerate it further. So all you've got is pressure reduction, and I don't think that's going to be enough mid-race to keep this person going and still be able to fit into a shoe. So it's torn and macerated. It's the end of activity, let's say, but they've got to go back to work tomorrow and they're on their feet a lot. So it's not like they can just rest up. We've got to implement something here that's going to make a difference in terms of pain and still let this heal. It's a weight-bearing location. It's relatively clean, and this person has good self-care ability. So the complicating factor is the macerated blister roof. If this was soiled, if there was all dirt underneath that blister roof, that would get me thinking, well, and if I couldn't flush it out, we could just sort of lance this further to really scoop out any goo and debris and then fold that blister roof back over. Yeah, it's a bit of a tricky one, this one. What we're trying to do, you know, when you've got maceration, you want to leave things open to the air and dry out. But when you've got a torn blister, you want to cover it to keep it in the risk of infection low. So it's a bit of a tricky situation. You got any thoughts on that one, Alan? Yeah,
this is a difficult one. In my first aid kit for expeditions, I will carry biotin. Biotin, I might be tempted to try and just trim with a scalpel the little ridge of tissue on the fifth toe and just take some of that off, just thin it down a bit. I agree with you. I'd be reluctant to deroof the whole thing. I might try and clean it out as best I can, pull that bit of tissue back up and close the gap, and then see if I can get a piece of biotin over the top, which will absorb any of the moisture out. And as you say, if you can get that to dry up, it would probably heal up fairly quickly, in a healthy foot. It probably would only take a day or two, and the skin would dry out, and new epithelium would come across underneath. But yeah, critically here, get rid of that maceration, get rid of the fluid, which on a multi-day expedition, if your feet are constantly wet, gets a bit hard. But that is that depending where you were and the person, that could go from fixed up fairly quickly or pretty nasty fairly quickly.
Exactly, it could go either way. So what I would be doing is I would be putting an island, obviously antiseptic, and then an island dressing over it, and I'd be changing it frequently because I'm torn between wanting to dry it out and wanting to keep it closed. So I'd use the island dressing just to soak up any moisture, not just blister fluid and exudate from that blister base, but the moisture from the waterlogged skin. And I'd just be changing it as frequently as I could, so that I haven't got a wet island sitting on that skin the whole time. How about this fella? I would lance this. I see a lot of these in 6-day ultra marathon. The blister is caused here and it tracks to a less pressurized area. And it's easy just to focus on this area in terms of implementing your shear reduction, but you've got to focus it here. You could even forget about this, just pop a island dressing over that and get all your prevention happening here, like right there. So it's kind of distended and tracking, starting to get a little bit of blood in there. Let's say this was the end of the activity. It's impacted by footwear. If it wasn't, we wouldn't have this irritation. So often these are caused by the cup of the curvature of the heel cup of the insole or the orthotic. Sometimes the orthotic slips forward. In that case, you get them at the back. But even just the insole that comes in the shoe, and some, insoles that you can buy, they're relatively cupped, and they can cause these blisters. This foot's pretty clean. They're semi-able to monitor and self-care. It's on an awkward spot on their foot. It's on the lateral heel. So that is actually quite difficult to get to. So you'd really need to make sure people can actually get there, see it, and do stuff to take care of this blister. So the complicating factors here are the small amount of blood that is infiltrated and the reduced self-care ability. If this was mid-event, wouldn't change what I did. I guess at events I'm there so I can see them constantly to reassess. If this was, an individual in a race or an expedition, and they were on their own, they didn't have someone who specialised in blisters, then it might change. But yeah, it's tricky when people need to know a lot about blisters when they are particularly active, because most people wouldn't know what to do with this, as I said, and it would just get worse rather than better. Yeah. So yeah, it's important to implement the prevention where the cause is, which is over here. How about these? Now, these are deroofed, obviously, but I want you to imagine these were intact. The only reason I would deroof these blisters would be if it was infected or there was a lot of debris under that blister roof. So I don't think there'd be many times that I would deroof these. If the blister roof was kind of torn, it was really non-viable, then it's just going to end up an irritant. That's another reason why you deroof it, because it's already sort of halfway there. If it's macerated, able to monitor and self-care. So yeah, I guess if they had good gear, they knew what was going on. I'd like a hydrocolloid on any deroof blister. But they need to know how to look after it. It's not just put a hydrocolloid on and forget about it. They need to be able to monitor it and change the dressing. Assuming these were intact, I would lance these when it was relatively distended with fluid. So there was quite a lot of fluid in there, because the chance of it sort of tearing spontaneously is quite high. Particularly if it was mid-activity or they had some activity coming up, it would be more than likely they would get worse. If I wasn't able to implement a good prevention on this, then I'd be more likely to lance it. But even if I didn't, I'd still want to implement great prevention. I guess it's even more important to make them not get worse and to feel better. it's impacted by footwear. So that's the tricky thing. I guess if they could get around in their Crocs or thongs until they heal, then that would be a good reason why you might even leave it intact. It's relatively clean conditions, they're able to get to their feet, and there's no high risk status with this patient. Reasons that I'd leave it intact is if there wasn't much fluid, it was the end of the activity, they had nothing else coming up, they could wear their thongs or Crocs around, or they had an excellent shear reduction in place. If it was likely to get dirty, I'd be more keen to leave it intact. If they were unable to self-care again and immunocompromised, then you'd be more likely to leave it intact. But still monitor. We've got to be looking at it, or the patient has to be looking at it, because just because it's intact and not infected now doesn't mean it's going to be that way in 2 hours' time.
I would agree with all of that, Rebecca. I think that's I wouldn't deroof unless it was just about to come off. Now, in some of my situations when I'm mountaineering, when you put your boots on and you head out just after midnight to climb a peak, sometimes you just cannot get your boots off until you get back to a safe place. So you can end up with very bad blisters like that because you can't take your boots off on the side of a mountain when it's -10 and then start to deal with this. So sometimes you will end up dealing with feet on mountaineering expedition where there's been a large amount of tissue removed, and so when you take the boot off, they take their boot off, most of the back of the heel comes off in the sock, and so you're faced with it. And it's not because it wasn't hurting, it's just that you're not in a situation where you can address it.
Yeah, good point.
And then you've got to manage it in all the ways that you have just mentioned.
Yeah. All right, so in dealing with lancing and deroofing blisters, the gear that I use, because I often get asked this, obviously hand sanitizer and gloves. A bluey underneath is good. Sterile cotton wool balls and buds. Scalpel blade, that's generally how I lance blisters. Hypodermic needles, particularly for toenail blisters. I don't like using hypodermic needles just to lance normal blisters because the hole isn't really big enough and you end up having to put a lot of pressure on the blister to get the fluid out. Lancing a blister doesn't hurt, at least it shouldn't hurt. You're lancing skin that, just isn't going to be painful or bleed. So there's no need for it to hurt. And there's also no need for it to hurt to get the fluid out. So just make sure the hole is big enough. Sometimes it helps to put a second hole in somewhere else. And that helps. I just roll the cotton bud over the blister just very gently to encourage the blister fluid to come out, or just press on it very gradually, and that gets it out. Sharps container to get rid of everything. Normal saline for irrigation if you need it, and povidone iodine prep pack and sterile dressings, either just normal dry island dressings or Compeed for deroof blisters. What about you, Alan?
Just a little trick, because we do multi-day walks and carry everything ourselves, I've been using the Providine iodine prep pad under the dressing.
Yeah,
so
okay.
I just cut it to size. Now, if you pick up a pack of Inidine and you pick up a Providine iron prep pad and turn them over, they have exactly the same concentration of iodine in them. But the Providine iodine prep pad's only about 1/10 the price. So I actually just put that against the blister, then put the dressing over the top.
Fantastic. That's a great idea. Other things that people use: sewing needle, it's not sterile, so it's a bit dubious. Scissors, pocket knives, you'll find people use. Some people, this is blister threading. It's common in hiking. I don't like this method because, number one, the cotton's not sterile. Number two, to get that cotton through the needle, to be able to thread it through the blister, people generally sort of put a bit of spit on it and it's pretty gunky. So you're really just inviting bacteria into that blister. How they don't get infected routinely, I don't know. But it's quite a popular thing to do in hiking, particularly on the Camino de Santiago, etc. So yeah, a lot of people think, oh, if I just heat it up in the flame, then that will sterilize it. Well, yes, but not just any flame. And also, you know, if you're doing, some people use a pin or a needle or a what do you call them, paper clip, and heat them up. Well, if you're holding the end of that, that's going to be so hot you won't be able to hold it if you're holding it over a flame for it to kind of get sterilized properly. So that has its downsides. Also, it leaves carbon on the implement if it's not in the blue part of the flame. So that can put carbon deposits into the blister, which can be an irritant as well. Hot shots, common in the army, in hiking. You come across these, Alan? What
are they called?
Hot shots, where they inject TB-Co or Fry's balsam into the blister, and the idea is so they aspirate the blister fluid and then inject into it the TB-Co, and then press the blister roof down, and the adhesion helps hold the blister roof back onto the blister base. I'm not a huge fan of this. I think it's kind of unnecessary. It's very painful. Just lance it. And really the issue, if you do a hot shot and you don't do anything to deal with the blister causing forces, just because you've stuck that blister roof back down on the blister base doesn't mean that the situation's fixed. You still need to implement a really good prevention. So in my way of thinking, why put the person through that pain when you can just lance it, which is painless, pop some betadine on it, dress it up, and implement your good prevention. It's possible to get really, really great pain relief and for things not to go pear-shaped without needing to assist that blister roof to stick back down to the blister base.
Now, I haven't seen that, Rebecca, but from my experience, this would be quite complicated to do because you're often dealing with these things when it's raining and it's windy, to have all this gear out. In my earlier days of bushwalking, I used to use TB-Co after I had lanced the blister, and TB-Co is a great sealant. And what I found was it was sealing all the bacteria and everything into the blister. And they often were more problematic when I lanced them, painted them with TB-Co. I've now just don't use TB-Co at all. I lance them and dress them as you would a skin tear with a much greater success rate. But this looks to me like somebody's little pet thing that looks awfully complicated. And as you say, it would be terribly painful, I would think, to have the aspiration and then the needles go back in with TB-Co and pushed on it.
Yeah, not fun. I think completely unnecessary, but you know what they're like in the army. They like to be tough. Nail trephination. These little, these electrocautery pens, I've never actually held one, but this YouTube video was a really great demonstration of how quick and easy it can be. You know, you can drill through the nail to reduce the thickness of the nail to get the fluid and the blood out. You can gouge it out with a scalpel, but the pressure will make it uncomfortable. But a hypodermic needle, you literally barely need to press. You just twist it, and it gets its way through the nail pretty quickly without the need for too much pressure. So, you know, these would be great. I'd love to have one, but I don't see enough of these to warrant it. And a hypodermic needle is quick and easy, and it's stuff we've already got. Okay, Q&A. Nicholas still with us? Yeah, he's there. To lance, deroof or lead, is it different for diabetes? Well, we've kind of gone through that, and I hope that it makes it a bit clearer in that, yes, on the whole, our aim when there is high risk and immunocompromise, the aim is to reduce the chances of infection and to keep that skin intact. But sometimes, to prevent it from getting worse, if we can do this in a controlled environment, it is actually a good idea to lance, and sometimes, like Alan said, even deroof the blister, just to give us a nice clean blister base, so that if we're thinking about deroofing, nice clean and fully exposed blister base, and we can put our dressing on it so it has full contact, and you know, it has a probably has a better chance of healing that way. And that's not even counting if there's dirt and debris in there. So, you know, again, everyone's looking for a yes or no answer. It kind of depends. And I hope just going through those case studies kind of helped, you know, I guess answer that. Any questions about that, Nick? Just pop it in the chat box if you've got any questions and I'll get to it. Okay. Are there certain types of foot blisters you believe should always be deroofed or lanced, and how do you communicate these recommendations to your patients? Well, there's not really. There are nuances to it, like we've discussed, but on the whole, I'm looking to deroof a blister if it's infected or soiled, and sometimes when that blister roof is macerated or just non-viable and it's causing irritation more than anything. There was another thing I thought of. Oh, if it's kind of, you know, half hanging off anyway and you can't really sort of patch it back over the whole blister base, then sometimes it's just easier to get rid of it. Leave it intact. I tend to leave it intact. Some people prefer that. Some people just have the heebie-jeebies about cutting the skin, which is fair enough. You know, in all of these situations, I have a discussion with the patient and I always talk about, you know, the risk of infection. If we leave it intact, then, you know, it can't get infected, assuming that we can implement good enough prevention to make it remain intact. And then I talk about, but if we open it up in a nice, clean and controlled environment, we talk about self-care, or whether we can get someone else to redo the dressings, or perhaps they need to come and see me in 3 days' time to have a look at it, that kind of thing. I'm looking to leave a blister intact if it's not impacted by footwear and they've got no upcoming activity. So if it's on the outside of the little toe or the back of the heel, I'm more than happy just to leave that blister intact, particularly if it's not particularly distended, and knowing that it will resolve. If I can get an excellent shear reduction in place, really I want to be doing that at any stage. But if I'm happy that I can put a good prevention in place so that that skin is going to remain intact, then I'm quite comfortable to leave it intact. And we're heading on the side of keeping it intact if they're high risk or there's immunocompromise. And in the middle are the ones that we lance. So basically anything that's likely to spontaneously tear. If it's taut and tracking, if the skin is relatively thin. So if we think about that second one, that blood blister on the interdigital space between 4 and 5, that skin was relatively thin there. It means that it's more likely to tear of its own accord. So I'm more likely to lance those. Mid-activity, if they've got clean feet, if they've got the gear, if they've got good self-care ability, or they're happy to come and see me whenever they, you know, let's say in a week or 3 days, or they've got some sort of home care help that can do that, I'm more likely to lance it. Peter and Mary, blister treatment, how to care for blisters during an extended athletic event, i.e. running from Land's End to John O'Groats on a mixture of trail and roads. Well, it really doesn't matter what the situation. When it boils down to it, the best treatment is not just the first aid, which is the dressing and the antiseptic. It's also the blister prevention. That's the thing that gets rid of the blister causing forces, and that's the thing that allows the blister to start healing, even though that person's got to put their shoes back on and keep going. It's the thing that makes it less painful. So to me, the prevention is just as important in treatment. How to manage hotspots. Now, to further that question about blister treatment and Hafsa's question about managing hotspots, if we just go back to this chart about the 5 blister stages. So we've got blister-free. The aim is to remain here. So I'll leave that there. I won't talk about implementing blister prevention where you've got a history of blisters and stuff. Then there's the hotspot stage. Well, this is your brief opportunity to stop yourself from getting into the blister stage. So it's the last stage of blister prevention. And the problem here is not many people stop and do something about it. Often they have the best intentions, but they think, oh no, it'll be okay. I'll just go another 5 minutes and see, or they'll be mulling over in their head, oh gosh, what am I going to do? What have I got in my blister kit? Blah, 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 if they've got anything at all. And in that time, they get that bit of a sting. It sort of progresses from like a little bit of rubbing sensation to actually a little bit of pain. And then some people will just not even feel it. You know, they're in the thick of the action, and the first thing they know is it's actually really quite painful. So the hotspot is easy to ignore, and it's easy to actually not get at all. And the problem is you've missed your opportunity for blister prevention. Ideally, though, you stop, you implement your blister prevention plan for that blister location, and I'll talk more about that in a sec. The next stage, if you don't do enough to stop it at the hotspot stage, you get into the blister stage where you've got an intact roof. The good thing about this blister is that it can't get infected if it stays like this. So the thing we've got to do is put our island dressing on after our antiseptic. Oh, sorry, we don't actually need antiseptic here. So it's really just an island dressing to protect the skin and implement our prevention, because the island dressing is well and good, but we can do better to stop the blister causing forces so it doesn't progress to the next stage, which is a torn blister roof. This happens if we don't do enough to keep it here. So we haven't addressed the blister causing forces enough. The bad thing about this blister is it is now open to infection. So betadine and a Band-Aid is the go here to prevent infection, plus your blister prevention plan to get rid of the blister causing forces for this blister location. If you don't do enough to stop it at this stage, you don't address the blister causing forces, you get into the deroof stage. And a deroof blister is more painful just because there's more exposed stratum spinosum. It's more open to infection. And so the idea here is same thing, dressing after antiseptic, but your compedes or your hydrocolloids are great for this and only this blister. Don't be putting hydrocolloids on any of these. Your patients are doing it, and some of them are getting away with it and raving about compede for all of these stages. But those who are unlucky enough to get a blister under a compede will know that is no fun, and it is a nightmare actually. So yeah, that is the aim of blister management. If we talk about our blister prevention plan, well, the idea is these are all the ways that blister preventions can work. So this one I kind of ignore. It means don't walk or run as far, not particularly helpful. This one is increase the skin's ability to deal with the shear. That will have already been taken place in your training. So hopefully you've minimized that issue and actually maximize the adaptions. The adaptions can only go so far though. So most preventions do this. They reduce the magnitude of shear distortion via one of these four means. So reducing friction force, that's what we're doing here is we're reducing the force that keeps the skin and the sock and the shoe lining in stationary contact. As the bones are moving back and forth in the foot, the skin doesn't follow, and there's that mismatch in movement. Now it's the job of the soft tissue between skin and bone to take up that shear, and it does it really well until it doesn't, and that's when you get a blister. So it may seem counterintuitive, but the idea is we need to somehow reduce that shear, and one way to do it is to reduce friction force by either making it more slippery or pressing together less hard, so reducing pressure. We're very good at this. We don't think as much about this, particularly in high-risk patients and ulcer management. It's a little bit harder to implement. You can't put Vaseline on a person that's got foot ulcers because it mucks up with the dressings that you've got in place. Yeah. Anyway, so we can reduce friction force by reducing pressure, reducing coefficient of friction. This is how all the moisture management strategies work. how Engo patches work, how Armour Skin socks work. They make it more slippery. We're pairing materials together that have easier slip and slide, and that is a good thing for blister prevention. Ideally, though, we do it in a targeted way, which is why I like the Engo patches. And if I'm using a lubricant, I kind of impress upon the patient to just use it where you need it. Don't put it over the whole foot, because the foot needs a bit of traction in the shoe. We can use materials that absorb shear, Spenco insoles, gel toe sleeves. We can spread shear load. That's what adhesive materials like tape, moleskin, and compedes do. It does it a bit. We're hardwired to thinking that taping stops the rubbing on the skin. But the truth of the matter is you can get blisters underneath tape, underneath moleskin, underneath compede, because it only reduces shear load by a little bit. It just reduces the peak shear by spreading it over a larger area, just like how cushioning works to reduce the perpendicular force. Materials that are adhered to the skin, they spread that shear load, because we don't just stick it right to the blister area or the blister prone area. We put big bits of tape, and the compede is bigger than the blister itself, that kind of thing. And we can reduce bone movement. Most of us never think of this. It's our bread and butter, really. Shear all starts with bone movement. The bone's moving back and forth in the foot, while the relatively high friction levels, which is inevitable because of the way the materials that the shoes and the linings and the socks are made out of, and because our feet sweat a lot, inevitably the skin exhibits a relatively high friction level. So skin stays still, bones are moving back and forth, everything in between stretches and distorts. So if we can address that bit, make the bones move a bit less, then we can prevent blisters. And my last tip is that think anatomically specific. A lot of us are looking for, and a lot of our patients are looking for, just the one thing that they can do for blisters, but there is no one thing that is the best thing for all anatomical locations. This is massive. This is how we really get great prevention, and how we get great pain relief, and how we allow blisters to heal, even though people have to still be active. We've got to pick the prevention for the anatomical location. And that's how I write about blister prevention. It's all about, where is this blister? Radio, let's think about how the bones move, friction, how we can, do all of that. So if you need a hand with that, have a look through my website, go to Blister Prevention University. That's what that whole course is about up here, pro.blister-prevention.com. And that should help you out in regards to implementing great prevention for all the blister locations. So with that being said, wow, we're massively over time. Are there any questions? Just wondering about the chances of a blister going deeper if not drained or deroofed. Yeah, it's probably, yeah, they can go deeper and they can track, the blister fluid can track. But really the best way that you can stop a blister from going deeper is to implement a great prevention, whether you lance it or not. If you implement a good prevention, you're going to stop the blister causing factors, and that will make it feel a lot better and also not get worse. I'll always remember at my first ultramarathon, I treated a blister under the ball of the foot for someone who was about to pull out of the race, and he was able to keep going for another 60 Ks or 30 Ks or something, or 3 hours, and he had no pain, and it was under the ball of the foot. And all I did was felt deflection, Engo patch, rectangle Engo patch under the on the insole, and lanced it and a dressing, and he was pain-free. So if you address the blister causing forces well enough, you can definitely make a blister pain-free. You can definitely help it heal, even though that person's got to be on their feet still. You just need to have the right gear. So hope that helps, Nick. No other questions, Alan?
No, it was good. Thank you.
Thank you. Thanks everyone for joining. So we'll be back the first Wednesday of next month. Don't know the topic yet. If you've got any ideas, you want me to talk about any particular topic, then let me know and I'll be sure to cover it. Thanks, guys.
Terrific. Thanks very much. Thanks for putting it on, Rebecca.
Thank you, Alan. Catch you later.
Thanks. Bye.